This conference will now be recorded.
Bismillah ar-Rahman ar-Rahim. Hello all my dear friends. Today we are going to discuss three stations.
Did you finish your tea?
Please, everyone, can you mute yourself? Keep unmuted, please. Okay. So today we are going to discuss about two topics, perineal tears and outpatient hysteroscopy. And in our session, we will discuss the three stations, one a teaching station and one role player station and one viva station, just to remember how to approach those stations. So we will start by the first station. Dr. Seema, please unmute yourself to practice it. Dr. Seema.
Hello.
Hello, Dr. Seema.
Hello. Hello.
Hello, can you hear me?
Yes, I can hear.
Yeah, okay. So this is your station. It's a simulated colleague task. Assess the following core clinical skills: patient safety, communication with colleagues, and applied knowledge. You have been asked by your consultant to meet your colleague Sophie, an ST3 doctor who is interested in minimal access surgery and wants to learn about outpatient hysteroscopy. You have 10 minutes during which you are expected to explain indications and contraindication and how to carry out safe outpatient hysteroscopy. Take 2 minutes to start the station. Are you ready to start, Dr. Seema?
Yes, ma'am.
Okay, start please.
Hello, I'm Dr. Saima. I am ST5. May I know your name?
Yeah, I'm Sophie, the ST3.
Sophie, nice to meet you.
Nice to meet you too.
Okay. Sophie, I understand that today you are here because you want to learn about outpatient hysteroscopy. Am I right?
Yes, that's right.
Okay. Okay, before that, can you please tell me when you joined your training?
Yeah, everything is fine, Zion. Thank you.
Okay, and how is everything in the department?
Everything is fine. You are a very nice department.
Okay, that's good. Sophie, at any point of time, if you have any problem, you can come and ask to us, and everyone is helpful here. Okay?
Thank you.
Okay. So, can you please tell me why you want to learn about outpatient hysteroscopy?
Yeah, I'm interested in this field and I'm looking forward to be sub-specialized in minimal access surgery.
Oh, that's very good, and that you are keen to learn about that. So today,
Yeah.
what we will do, I will tell you about what are different indications of outpatient hysteroscopy, what are different contraindications, and how the procedure is done, and At the end of discussion, I will provide you some useful links. There are some videos in the strategy. And if you have any question, you can stop me at any time and I will be very happy to tell you. Is it okay?
Yeah, that's fine.
Okay. So now I want to tell you about different indications. Outpatient hysteroscopy, it is a small procedure. It is just done in the outpatient department and it is just a 10 to 15-minute procedure. There are various indications like the patient with abnormal uterine bleeding, like the patient which have intermenstrual bleeding, or sometimes the woman has history of infertility, or sometimes there is a history of recurrent miscarriages. Okay, and sometimes we are suspecting some polyp or some fibroid inside the cavity of the uterus, which we have already seen on the ultrasound. Okay, okay. And it is a safe procedures, but there are certain risks like any other procedures. So it is very much important that we rule out any contraindications. Okay, do you want to know about contraindications?
No, I don't know.
Okay, so first of all, the patient, there should be no infection. We will rule out that there should be no any vaginal discharge or any infection. Okay, and then the patient should not be pregnant. So it is very much important to ask about the last date of last menstrual period, and you can also confirm by doing a urine pregnancy test that the patient is not pregnant. Okay. Okay. So when we have planned to do this procedure, we will ask the patient to come on the day of procedure. Okay, and you will take a consent from the patient, and you will tell all the risks of the procedure, and you will sign the consent. Okay, patient can eat and drink because it is outpatient procedure. It is done without anesthesia, but patient is offered to have a small some medication like NSAID medication, like you can give 1 gram paracetamol or 400 milligram ibuprofen 1 hour before the procedure. Okay, and patient is put in the lithotomy position, and this procedure can be done by putting a speculum, or sometimes we can use no touch technique by using a vaginoscopic approach also. Okay, and women who have already given birth, they don't need any cervical dilatation, and this small hysteroscope, which is used for diagnostic purpose, this is just a 3.5 millimeter hysteroscope. This can be inserted inside the womb, and we can look inside the womb. Okay. Okay, am I clear so far?
Yes, clear.
Okay, so look at the picture here. This is a hysteroscope and there are different parts of it. First of all, this is the camera which is attached behind, and then there are different ports. One is for attaching the light source, one of them is for attaching the saline or any fluid port, and then this is the rigid hysteroscope which is entered into the obturator, and at the distal end there is a lens, and at the proximal end there is a eyepiece. Okay, and
Yes,
it is
okay.
attached with the camera. Okay, so this is entered inside the cervical canal. First of all, you will open the saline, okay, and gently you will enter inside the cervix, and you will introduce it into the cavity, and when you will reach just 1 to 1.5 centimeter behind the fundus, you will stop it and you will just rotate it, and you will have a clear view of the cavity. You can see the fundus, the ostia of tubes, anterior wall, posterior wall, and you will take the images, and you will see is the lining of the womb is regular, or is there any polyp, any adhesions, any fibroids, and the pictures are taken, and when you will gently remove it, you can also have a view of the cervical canal. Okay, Okay, am I
Okay.
clear so far?
Yes,
Okay.
clear.
Okay. So after the procedure, the patient can have small amount of bleeding or pain for some time, for which you can give her some painkillers. Okay, but you can tell the patient that if she has heavy bleeding, or if the pain is very much, or if there is any discharge, then if she has any fever, then she can immediately contact to the hospital again. Okay, you can
Okay.
give her contact. You can also give her contact number. Okay, but if the patient, if the procedure goes without any problem, then you will discharge the patient about after observing for about half hour. Okay.
Mm-hmm.
Okay, and you can also take a small sample of endometrium if it is done for this purpose.
Mm-hmm.
Okay, which we call as endometrial biopsy. Uh, do you have any other question?
Yeah, what are the differences between the two hysteroscopy which we have today?
Yes, there are two types of hysteroscopy. One is for the outpatient hysteroscopy. It is for just diagnostic purpose. While the other hysteroscope, which is for therapeutic purpose, it has more channels, and it is larger than the diagnostic one. Okay, and
Mm-hmm.
it is done in the in the operation theater under anesthesia.
Mm-hmm. So
Okay.
we are not able to do any operative measures in outpatient hysteroscopy?
We can take a biopsy, just we can take biopsy, but if there are any polyp, any fibroids, then it is done under uh, in the operation theater with the operative hysteroscope. Okay,
Mm-hmm.
because there are some channels through which we can enter some instruments like resectoscope, or sometimes laser can also be used, but this can be done in operation theater under general anesthesia.
Okay.
Okay. Uh, okay, Sophie,
So
how
what is the best distension media which we can use in outpatient hysteroscopy?
in the outpatient hysteroscopy, we can use carbon dioxide as well as normal saline. Both media can be
Mm-hmm.
used. But in case of operative hysteroscopy, we use normal saline or glycine, but we don't use carbon dioxide. Okay.
Mm-hmm. Okay.
Okay. So any other question?
No, thank
Do you have
you.
any other question? Okay. So how was today's session, Sophie?
Yeah, it was very nice session. Thank you.
Okay. So I'm happy that you are a very fast learner. Can you please repeat different types of hysteroscope for me?
Yeah, there is diagnostic and operative hysteroscopy.
Okay, that's good. So
Mm-hmm.
I'm providing you useful links, and there is a very good guideline, green top guideline, and there are excellent videos in the strategy. You can watch them, and if you have any problem, you can come back to me. Okay.
Okay. Thank you.
Okay.
You
Thanks
finish
for
on
your time.
time. Thank you, Dr. Seema.
Thank you, Dr. Aisha.
Thank you. So what do you think about your performance?
Uh,
I'd like to hear from you your own feedback. What do you think?
uh, I tried to cover the main points,
Mm-hmm.
but the time was very short, so I
Mm-hmm.
just covered the main
Okay.
points. Mhm.
Okay, Dr. Seema. So the good things you did that when you start the station, you introduce yourself with your name and role and without seeing doctor, and you set the aim of the meeting, and you establish good rapport with the candidate when you ask about how about her training and what about her performance in the unit. And it's very nice for me also that you ask why she's keen to learn about our patient hysteroscopy. And other good things that you mentioned, the consent and the lysotomy position, and the method of entry could be through speculum or using a vaginoscopic technique. And you check understanding frequently by asking, am I clear so far? and by the end you ask about the feedback, and you give me chance for further learning by giving me many sources for future learning. It's really very nice from you, and the best thing you did that you finished the station in time. But coming to what could be improved in next time, you didn't check for my basic knowledge. You need to ask the candidate what you already know about our patient hysteroscopy. And also,
Okay.
when you mentioned about the indications in outpatient hysteroscopy, it could be diagnostic or therapeutic. We can do some
Okay.
minor operation in outpatient hysteroscopy, like removal of missed IUD, or a small polyp could be removed also outpatient. And if a small fibroid type 0, which has a fibroid within the cavity, you can also remove this. If there is minor adhesions, you can remove this adhesion in outpatient hysteroscopy. So the indication, you can subdivide it into diagnostic and therapeutic. In terms of contraindication, you mentioned it well. Also coming back to your performance in teaching station, try to don't give lecture. Stop every time and check the understanding, and don't leave the question which you need to assess her learning at the end, because sometimes you will not have enough time for doing that. At the end of the station, you recognize that you didn't ask me any question. But if the time was run, you cannot do this and you will miss this mark. So don't give
Okay.
lecture, stop and check understanding frequently and invite questions as well. The other thing that you really did it very nice when you use the props, when you explain to the candidate on the telescope she has, what is the part and what is the difference between the two hysteroscopy. It's really important in any teaching station, if you have props in front of you, to use these props, because there is a mark on using these props. The other thing you forget to talk about by manual examination and the presence of chaperone, and it's a really important point in safety in this station. And don't forget hand washing. And don't forget, in any post-operative care, the proper documentation. You need to document everything. Okay? And when you are uncertain about answering the question the role player asked you, when I ask you, can we do some operation in outpatient hysteroscopy, you are not sure about your answer. So to be in the safe side, till here it's not up to my knowledge, I will check and come you later. So you will at least not give negative mark for this wrong answer. Am I clear, Dr. Seema?
Yes, yes, ma'am.
Apart from that, you did it very well. Thank you for your performance.
Thanks, you gave a very good feedback.
Thank you. So just I'd like to revise again how we approach the teaching session. As Dr. Seema did, when we read the instruction, we said before, you need in the 2 minutes to answer what are you going to teach and who you are going to teach. In this station, you are the ST5 and you are going to teach about outpatient hysteroscopy, and you need to read what are you expected to do in the 10 minutes. As in the station, it's written indication and contraindication, and carry out a safe outpatient hysteroscopy. So in the 2 minutes, remember who am I and who I'm going to teach and what is his role and what is the topic, and if there is details of the topic that I'm going to discuss. You need also to introduce yourself in confident manner and establish a good rapport between you and the role player. Enter the cubicle and said, hello, my name is Rasha, the ST5. May I check your name? She will tell you her name. Nice to see you. And all through the station, don't forget to maintain eye-to-eye contact with the role player. And when she talks, to be an active listener, you need to do head nodding. And you can practice this while practicing with your study partner with video call. Practice eye-to-eye contact and head nodding. Because if you are not familiarize yourself with doing this, you cannot be able to do this in the exam. So try to practice eye-to-eye contact and head nodding, because it is good indicators that you have a good communication skills. And also remember, when you read the station, sometimes it's written this candidate is recently joined the unit or is about to have an exam. So you need to be aware of this situation and mention this in the station. You can see, I can see that you are about to have an exam. How about your preparation? So you are aware about the condition. After that, in the teaching also, it's important to set the environment. How to set the environment? The aim of the teaching, you want the candidate to know what you are about to teach. And in order to do this, the props need to be equidistant between both of you. I enter the cubicle and there is hysteroscopy on the table. I will move my chair to be nearer to the role player and put the hysteroscope midway between both of us. Other issue is you need to explain to the role player your agenda, as Dr. Sima did. We are about to talk about our patient hysteroscopy indications and contraindication and so on. And also, it will be better if you ask the candidate, do you have any more concern? So you can answer in the station. You need also to explain, if there is props, you need to explain on it practically. And try to ask the candidate to repeat what you did on the props. Leave the question of assessing her learning by letting her did what you did, letting her do what you did. If I'm going to tell her that I will going to assemble the hysteroscopy and I show her to do that, ask her to repeat this, okay? And remember, when she repeats the procedure in front of you, to be careful that she didn't make any mistake, because usually she will do a mistake and you need to pick this mistake and correct it and ask her to repeat it again. Remember, you are not going to give a lecture. You need to chunk and don't chunk. You need to invite questions. You need continuously to check the understanding. Simple question, am I clear so far? Does it make sense? How does it sound? And when the role player answers the question correctly, appreciate that. Great, brilliant, perfect. If the role player does something wrong, do not interrupt her. Let her finish, then sit. Let's go through it again, and you correct what she did and ask her to repeat again, then appreciate it. Don't forget to use the appropriate language. If you are going to teach a medical health professional, it's okay to use jargons. So, and even if you use lay language in the teaching station, it will be against the communication. So take care of this point. Use jargons only. And when you close the station, it's important to make sure that this candidate don't have any more concern. And if you have time, you can summarize what you taught him. Usually you will not have enough time, but if you have, do summary. And it's important to also to ask about the feedback. And remember that the feedback is dual, for your feedback and for her feedback. Ask her, how did the session go? And then tell her you did very well. And to gain more benefit, I'd like to give you more sources to go through it again. Don't forget also the consent, introducing yourself to the patient. If it is props and you apply it on a patient, don't forget the consent and introduce yourself to the patient. And don't forget the chaperone, and know your limitation and be careful when you need to seek help. And don't forget hand washing, and in the post-operative, don't forget documentations. Anyone have any question relating to the teaching approach? Is it clear now? Any questions?
No, it is clear now.
Okay, Dr. Sina. So coming to the outpatient hysteroscopy. The first question in the station, you need to talk about indications and contraindications of outpatient hysteroscopy. Indication of outpatient, it could be diagnostic or therapeutic. Diagnostic, mainly 3 points: abnormal uterine bleeding, and during the subfertility workup and recurrent miscarriage workup. This is enough. I just write some details, but because you will not have time, summarize it as the following. Only for workup for abnormal uterine bleeding, recurrent miscarriage, and fertility workup. This is the diagnostic outpatient hysteroscopy. But for the therapeutic indication, we can do direct endometrial sample, endometrial polypectomy, minor adhesiolysis, resection of some submucous fibroid if it is 100% within the cavity. You can localize and remove with the IUD, do endometrial ablation and outpatient sterilization. And also, you can pick only 3 of this. So, indications, diagnostic or therapeutic. Diagnostic, abnormal uterine bleeding, fertility workup, recurrent miscarriage. Therapeutic, endometrial sample, with the ISD, endometrial ablation, small polyp, and zero-type fibroid. What are the contraindications? You mentioned infection and pregnancy, but also cervical cancer is a contraindication for hysteroscopy. And if the patient is experiencing a heavy uterine bleeding, you will not see anything from the hysteroscopy. So the contraindication are infection, pregnancy, cervical cancer, and heavy uterine bleeding. Now we have props in front of us, and we need to tell the role player what is this part. Here is the image of the hysteroscopy. As you can see, part 1 here, it is the video camera and the monitor. You attach this video camera to the eyepiece. Here, number 2, it is the light source and light lead is attached here. Number 3, it is the hysteroscopy within its sheath. And here is number 4 is the channel for the distension media used for during the hysteroscopy. So you need to tell the candidate this part, and then you can ask simply, what is this part? She will tell, for example, this is the eyepiece. So take the props and explain its parts. And you need to learn her how to assemble the hysteroscopy. So in order to assemble the hysteroscopy, you need to attach this eyepiece to the camera. Here is the eyepiece and there is the camera. You need to attach those to each other. You need to attach the light source. And you need to insert the telescope inside the sheath. And remember, the sheath could be single channel or dual or continuous channel. Single channel, it will be only for diagnostic hysteroscopy because it has only one channel to insert the distension media. There is no any other port to enter an instrument. So if it is single channel sheath, remember, it's a diagnostic hysteroscopy. And before applying the hysteroscope, you need to check the white balance by simply switch on the light source and check on the monitor the white balance is setting correctly. So to summarize the important steps of hysteroscopy, you need to clean and wrap the patient, performing by manual examination. You need to perform by manual examination to make sure the size and the volume and the direction of the uterus. It's a point of safety, don't forget it. If you are going to do conventional hysteroscopy, I mean that don't using the non-touch, so you are going to insert the speculum and then insert the tenaculum to grasp the anterior lip of the cervix and then insert the hysteroscopy. But in the non-touch technique, there is no need to use the speculum or the tenaculum. In the outpatient hysteroscopy, usually you will not require anesthesia. The patient is counseled to take non-steroidal anti-inflammatory drugs 1 hour before the procedure. But in selected cases, like if the patient is nulliparous or she has a cervical stenosis, whatever, you can apply local anesthetic to the cervix. Usually also in the outpatient hysteroscopy, you will not need to dilate the cervix. But if there is narrow cervix, you can do the dilatation. But usually you will not need, because the diagnostic hysteroscopy, its diameter is very thin. It's only 2.7 millimeter, and within the sheath it is about 3.5 milli. So it will be easy to introduce the periscope without dilating the cervix. But if you are going to dilate, important point of safety, if you are going to dilate the cervix, don't let the dilator to touch the endometrium. Only dilate the cervix and don't introduce further. Because if you touch the endometrium and cause a trauma in the endometrium, this can lead to bleeding, which can obscure your vision, and at the same time, it could increase the risk of fluid and gas embolism. The other thing, we first clean and wrap the patient and do by manual examination, inserting the speculum, apply the anesthetist if required, do the dilatation if required. Now you will place the hysteroscope against the external cervix, and now you will start the distension. The uterine distension will be started only when you introduce the hysteroscope to the external cervix. And then you will gradually guide the hysteroscope into the trying cavity, and don't forget to mention under direct vision. It's also important point of safety. The hysteroscopy to be introduced under direct vision. Okay, so if we are going to use the non-touch technique, what are the difference? In the non-touch technique, there is no speculum, there is no tenaculum. So what you are going to do, as in these images. Number one, you will introduce the hysteroscope into the lower vagina without speculum. Then you will start now the infusion with normal saline. As you can see in this image, when you do the saline infusion, it will form a bulge here in the vagina. So it will distend the vagina. Now you will move the hysteroscope to touch the lower part of cervix and then guide it within the cervical canal. This is the non-touch technique, the vaginoscopic method. Introduce the hysteroscope into the lower vagina without a speculum, then start the infusion, then guide the hysteroscopy towards the cervix, and finally insert it into the uterine cavity. Don't forget that when you explain to the role player or the candidate about the hysteroscopy, if there is, because it's mentioned how to carry out safe in a hysteroscopy. So you need to mention some important point, like, as you know, the uterus is a virtual cavity, so we need a distension media, which could be carbon dioxide or normal saline in our patient hysteroscopy. Tell her that you know that the endometrium is supplied by rich blood supply. So if breached, this can lead to entry of the distension media in the circulation, and this can lead to gas embolism or fluid overload syndrome. So in order to avoid that, try to avoid trauma to the endometrium. Remember also to monitor the fluid balance if you are using operative hysteroscopy, the input to be equal to the output. If there is significant deficit, this could indicate the patient has fluid overload syndrome. Don't forget to tell the candidate that you introduce the hysteroscope under direct vision in order to avoid the uterine perforation. And don't tell that the person who performs the hysteroscopy should have the necessary skills to do that. Don't forget the chaperone. Don't forget that the patient needs to have written patient information left before the procedure, need to sign the consent, and also you can mention about the analgesic, as Dr. Sima mentioned, non-steroidal paracetamol 1 hour before. And as I said, the cervical preparation, routine cervical preparation is not necessary before our patient hysteroscopy as well. So in our patient, no necessary for no indications for general anesthesia, cervical preparation, dilatation. Usually we will not require all of this. It's important to mention the lithotomy position, the hand washing, manual examination, and the presence of a chaperone. As you can see in this image, here the patient lie in dorsal lithotomy position, and it's important to present the presence of the chaperone. Then assemble the hysteroscopy. As we said, we will attach the light source, check the white balance, and also it's important to run fluid to ensure there is no air bubbles. Insert the speculum if you are using the non-touch technique, or if you are using the conventional technique, or you can use the non-touch vaginoscopic approach. If you are using the usual method, you can introduce the tenaculum to touch or to grasp the anterior leg of the cervix. As I said, no dilatation is required usually. And while the distension media is running, you can guide the hysteroscope through the cervical canal. It's important to mention the hysteroscope needs to be guided under direct vision. Once you are in the uterine cavity, give time for the distension media to have a clear panoramic view. When you enter the uterine cavity, you will inspect in a systematic manner, locating the tubal ostia, see the fundus, the lateral wall, then anterior and posterior wall. As you know, the outpatient hysteroscopy have different degrees of the optic. It could be 0 or 12 or 13. Usually we use the 30-degree optic. If you are using 30-degree optic, if the tip of the scope is placed about 1 to 1.5 centimeters from the fundus, you can see at this point the whole cavity and one ostia. And in order to see the other ostia, you will just rotate the instrument on its axis without lateral movement of the scope. If the hysteroscopy has a 30-degree optic, 1.5 centimeters from the cervix, now you are seeing the cavity and one ostia. So now I need to see the other ostium. You will rotate the instrument on its axis. Don't do lateral movement, and this will reduce the risk of perforation also. When you withdraw the hysteroscope through the cervix, you need to check the cervix for any pathology. Don't forget the documentation. And as you know, the hysteroscopy which is used in our patient is thin, about 2.7 millimeter, and within the cheese it will about 3 to 3.5 milli. And in terms of the outpatient hysteroscopy distension media, we can use saline or carbon dioxide. And there is no benefit of carbon dioxide over the saline in terms of reducing the pain. Pain the same with carbon dioxide or with normal saline. But the benefit of normal saline is that there is less incidence of vasovagal episodes. And also, if you are going to use bipolar disorder, bipolar cautery, you will use the normal saline because it acts both as conduction and distension media. Does anyone have any question about hysteroscopy? Any point not clear?
دكتورة رشا معلش السلام عليكم.
وعليكم السلام.
What about this if we have like fluid overload? How much is normal saline? 1.5 or how much, and how we will treat?
You will, no, this is only an operative hysteroscopy. You need to measure the amount of fluid input and output. And if there is significant deficit, it has a characteristic number for the saline and for the glycine. It's not up to my knowledge now the number. But if you reach this number of deficit, you will inform the anesthetist and you will resuscitate the patient because she will have pulmonary edema and she may become hemodynamically stable. She may have electrolyte imbalance. That's why it's important to monitor the input and the output. Once you reach the specific deficit, you will stop the procedure and evaluate the patient and resuscitate him. Is it clear?
Okay, thank you.
Any more questions?
Hi, Dr. Rasha. Assalamu alaikum.
Wa alaikum salam.
How are you? How's your father?
Yes, thank you, Dr. Salma is fine. Thank you.
Yeah. Just I would like to ask that when you ask her that about the type of the hysteroscopy, so do you think that it will be rigid and flexible hysteroscopy, or that one what she told that?
Okay, you can, but yes, you have a rigid hysteroscopy and flexible, but we use the props which is available in the station. In the station, you have here two types of hysteroscopy. Both are rigid hysteroscopy. One is diagnostic and one is operative.
Okay.
No. Both are rigid and here. Yeah, okay. Tell me about your question.
So only that this one is operative and.
Sorry, Dr. Salman?
Here it is mentioning that operative and that one is operative and another one, what you told here?
This is diagnostic only. Look, in the above hysteroscope, in this image, there is no channel to enter the instrument. But here, the lower part, look in the arrow. This channel, we can introduce instruments through this channel. So you can do polypectomy or adhesolysis from this channel. But the above one don't have this channel. This is the difference between both.
Yeah. So that means we can tell only the therapeutic and diagnostic, that one here.
Only the first one is diagnostic. The second one could be diagnostic or therapeutic.
Okay, thank you. Thank you.
Clear?
Yes.
Okay. Any more questions? Clear now? Shall we move? Okay. So who would like to practice the second station?
Can I try, ma'am?
Yes, sure. Dr. Lasa?
Lata. Yes.
Lata. Okay. This is a simulated role player task. Assess the following core clinical skills: patient safety, information gathering, communication with patients, and applied knowledge. You are an ST5 and have been asked to help at the antenatal clinic because the consultant has been called away at short notice. The patient you are about to see is a 32-year-old scientist who has been referred by GP for management advice. In the referral letter, it was written, "I will be grateful if you would arrange to see Mrs. Goodnight at your antenatal clinic." And she has just moved to the area and she's currently 6 weeks pregnant and she delivered 2 years ago and has third-degree perineal cyst. She would like to discuss about the move delivery. You need to take a focused history and justify a management plan and answer her concerns. Dr. Latta, please try to be in a more quiet place because there is a noise from your side.
Oh, okay, ma'am. Just 1 minute.
Okay. I will give you now 2 minutes for your preparation.
Sorry, ma'am. Is it any better now?
Yeah, you have now 2 minutes. Try to prepare yourself in 2 minutes.
Okay. Okay.
Are you ready?
Yeah. Hello, I'm Dr. Lata, one of the doctors in the antenatal clinic today. May I confirm your name and age, please?
Yeah, Mrs. Goodnight. I'm 32 years.
How can I call you?
Mrs. Goodnight is fine.
Okay, Mrs. Goodnight. So I do have your GP's letter with me. I understand that you are 36 weeks into this pregnancy, and because you have had a big tear in the previous pregnancy, you're here to discuss about the delivery options. Is that correct?
Yes, correct.
Okay. Mrs. Goodnight, is there any particular concern that you would like to be discussed in today's meeting?
Yes, I'd like to have my current pregnancy ended by a cesarean section. I don't like to go through the bad experiences that I had in my previous one.
Oh, I'm sorry to hear about that. Can you please tell me more about what had happened?
Yes, 2 years ago, I were delivered. I were induced with sleeplessness actually before my water were broken, and then I went into labor very quickly. I were looked after by a student midwife because the delivery suite at this time was shortlisted, and everything occurred very rapidly. I remember that they told me you need to sharply push because your daughter is distressed, and we need to get it out within maximum 2 pushes. And then I experienced a very bad tear, and they rushed me to the theater in order to do this repair. Actually, it was a very bad experience. That's why I'm keen this time to deliver my baby by cesarean section.
Oh, I'm so sorry, Mrs. Goodnight, to hear about all that what you had undergone. May I know how your recovery was after that?
Actually, I didn't have any follow-up after that, and unfortunately, I suffered some incontinence. But after about 4 months from my delivery, everything is went well.
Okay, so at the moment, do you have any symptoms related to that? I mean, any problems related to that with regards to your,
Like what?
sorry, with regards, yeah, like any problems with your bowels or any problems with your waterworks, any pain, any lasting pain there, anything of that sort?
No, no. All the
Okay,
symptoms
and as
disappeared
such,
now.
okay, that's good. Okay, and you said that the baby was in distress at that time. How is your daughter right now?
No, she's fine. Thank you.
Okay, okay, Mrs. Goodnight. And so because you're 36 weeks right now, and how has this pregnancy been so far?
Yeah, everything is fine.
Okay, have you named the baby yet?
No, not yet.
Okay, how is the baby moving?
Yeah, it's fine.
Okay. Uh-huh. So, so am I right in understanding that this is your second pregnancy?
Mm-hmm.
Okay. So I'm not sure if you have made up your mind at the moment. So do you have any further plans for future pregnancies?
Yeah, I'm keen to have at least 4 children.
Okay, then. Okay. Uh-huh. So apart from this, Mrs. Goodnight, are you generally fit and fine?
Yeah.
Okay. Any other surgeries at all?
Sorry?
Any other surgeries in the past?
No,
Are you allergic to anything, any medicine or any
no.
metal or any food? Okay. May I know your height for weight ratio?
It is within normal, I think about 22.
Okay. Any significant family history of clots in the legs or lungs, anything of that sort?
No,
Okay. Okay. Do you smoke?
no,
Do you take alcohol?
no.
Any recreational drugs? Okay. And how about the support at home, Mrs. Goodnight?
Actually, I recently moved to this city, and my husband is working. He is import and export manager, so he used to travel a lot. But we have a good relationship. But apart from support at home following delivery, I think it will be some sort of difficult.
Okay. Mm-hmm. And in the past few weeks, have you been low down, depressed? How was your mood been?
No, everything is fine.
Okay. So also, Mrs. Goodnight, with your permission, I will just go through your previous delivery notes just to
Mhm.
see if any added medical information could be obtained. Is that okay?
Yes, okay.
Okay. So thanks for sharing all that information, Mrs. Goodnight. Is there anything else that you would like to add to it?
No.
Okay, so will it be okay if I just examine you in the presence of a chaperone, just to have a look at the pregnancy and to have to look to see for baby's heartbeat, and then just to see them down below. Is that
Okay.
fine?
Okay.
Okay, so yeah, so with regards to the options, Mrs. Goodnight, apart from I know it was very difficult for you last time. Apart from that, is there any particular reason you're interested in having a cesarean section delivery this time?
Yeah, because I don't want to again suffer from a tear and this bad symptoms. I'd like to have a safe delivery.
Okay, okay, Mrs. Goodnight. So this time the options are, and also you have mentioned you have had a tear in the previous pregnancy, but at the moment you don't have any symptoms. So that's the reason you can go for either a normal delivery or a cesarean section delivery at this time. And because I know you are more keen for cesarean section, but will it be a good idea to discuss about the pros and cons of both the options so that you will be in a better position to make a decision for yourself?
Mhm. Okay.
Okay. Okay. So first, with regards to cesarean, because you opted for it, yes, you're right in saying that you may this time the chances of getting a tear as in could be reduced, because 5 in 100 women will have a tear again, so that chance is reduced in cesarean section. But then because also you're thinking of future pregnancies, as such at the end it's a surgery, so during the time of surgery there could be problems, as in though we'll be very, very careful, there could be chances of any injuries to the there could be difficulty in times of delivering, or there could be any organ injury, or in because you have opted for because you're planning for a big for future pregnancies, it might impose with problems with afterbirth in the future pregnancies as well. So for all these reasons, that's about the cesarean section. So if you were to go for vaginal delivery this time, because you do not have any symptom at the moment, usually it is seen that about 80% of the women are okay. Like in your case, they do not have any symptom and they get along get along delivery very well this time, even if you were to opt for vaginal delivery, and there would not be even any need for mandatory compulsory cut to be given. Am I clear so far?
Oh, so if you give me a try for vaginal delivery, there will be no cut from down below?
No, I'm saying that usually you might, if you were thinking that we may have to give a cut there, so usually that is not the case. Is that what I'm saying? Like it's not routinely done. We can still, we can still deliver you like how we would do with every other delivery. And the good thing about this is that you will have early recovery, early skin to skin with the baby, and you will be discharged home early, because you said that there is no support at home and that you have another elder kid as well. But the problem with this is that there is a chance of your, as I said, there is a 5 in 100 chance of the same tear, big tear, as in tear extending to the anal passage occurring again, and also your symptoms might get a little worse this time if it were to happen. It is not necessary that it should happen, but if it were to happen, so these are the problems. Am I clear so far?
And so how are you going to reduce the incidence of these complications? I don't want to have again tear or again symptoms.
Yeah, definitely. So you will be delivering with us in the consultant-led unit, and we'll be using a multidisciplinary approach, wherein consultant will be involved and the specialist midwife will be involved in your care. We will be making sure that at the time of delivery, there are certain measures to be taken, as in controlled delivery of the head, and giving additional support to the area there. And we'll be acting promptly as to what is to be done at that time. Like we'll be more careful with the delivery. Okay. And any questions so far?
No.
Okay. So do you think anything in your mind? Have you made up any plan at the moment?
I can't make my decision at the right time.
Okay, that's fine. That's absolutely fine. I may suggest I'll give you some information leaflet which you can carry home and discuss with your partner and get back to us. I'll write another. I'll fix an appointment with the consultant and we'll write back to the GP as well. You can also go. I'll share you some links of support groups which you can go through, because you can understand from people who have been in your situation. And till then, because you're already 36 weeks, keep a track of your baby's movements, and if you were to have any tummy pain or leaking or bleeding, please get back to us, because we need to rule out that you have started labor. Okay. Thank you so much, Mrs. Goodnight. Thanks for your time.
Thank you, Dr. Lata. You know that the time is finished within about 1 minute. So whatever you said after the time finished will not be counted for you. So when the time finished, stop and move to the other station. Okay?
Okay, ma'am.
So now you did it very well. Thank you for your performance. And from the start, you confirming the aim of the consultation, and you ask the patient about her main concern. And when you ask her about the health of her daughter, it's really nice from you. And you ask about details of her current pregnancy, and a nice question when you ask about her future fertility. And also, you didn't forget about psychological history. Whenever there is a pregnant woman either during pregnancy or postpartum. Psychological history is very important. And it's really nice that you mentioned you need to review her notes. And also, when you tell her that I'd like to discuss with you about the pros and cons of cesarean and the vaginal delivery to make your informed decision. So you don't make a decision instead of her, you just give her the information and she is the one who will decide. This is very nice from you also. And when you answer that routine episiotomy is not necessary, and we will deliver you in a consultant unit, and we will support the head during crowning, all of this as a preventive measures. You did very well by mentioning all of that. But on the other hand, when you read the station here, you can see
Yeah, the consultant is, has
Yes,
been called
yes,
away. I completely missed on that. Yeah.
So if you didn't mention this, you are not aware of the situation. You need to take the permission of the patient. May I see you today on behalf of my consultant? This is from the start of the consultation. And also, when you read, I know that when you read the station, you picked this, but inside the station you will forget. So in order not to forget, write this in the notes you will have on the exam. You will have notes in your hand, write consultant is away, so you cannot forget it inside the cubicle. Other thing that signposting before any embarrassing question. You asked her about bowel incontinence, wind incontinence. This is a very embarrassing questions to ask. So signpost before that. I'm sorry if you find some of my question intruded or embarrassing, but I need to ask, then ask your questions. Also, the history take from you more than 5 minutes. It's recommended to finish the history within 3 minutes maximum. So you will have enough time for the consultation, because the main marks of the safety and the knowledge will become after the history taking. So by any way, try to finish the history within maximum 3 minutes. With practice, you can do it. Another point is that you forget to talk about the follow-up after her vaginal delivery, which is very important. After your delivery, you will be advised to practice a pelvic floor exercise, and you need to ask if she already practiced this in her previous pregnancy or not. So the follow-up visit, after 6 to 12 weeks, you need to be seen by the consultant. And still, if you have symptoms, we could do a referral for you to a specialized doctor, because you see, in the station, there is mark for no, there is no communication with colleague. But if you find there is a communication with colleague, here is the communication. Communicate with the consultant, and in the follow-up, if she's still symptomatic, you need to do referral for a colorectal surgeon or gynecologist specialized in obstetric anal centric injury. Another issue we said before in our sessions, the point of patient information leaflet and support group. It is a granted mark. So in order, instead of leaving it at the end of the station, you can set this when you tell her the diagnosis or what are you going to do. Like when I set the agenda, I'm going today to discuss with you about your management plan following third-degree perineal tear in your previous pregnancy, and by the end, I will give you patient information leaflet about perineal tear and put you in contact with support group. Then start your consultation. So you will guarantee this mark, because at the end you will not have enough time for this. Another issue that you talk about the benefit of the vaginal delivery and the risk of the vaginal delivery, the risk of recurrence of the tear. But remember, there is also risk of recurrence of symptoms. Even if the patient didn't suffer recurrent tear, there is a risk about 1 in 5, about 20%, that she will be symptomatic after her vaginal delivery, and you need to tell her about it. And also, I'd like to ask you a question in order to remember you by this point. When you offer the patient vaginal delivery following previous tear of perineal tear, when you will offer her vaginal delivery?
If she has no more plans of future pregnancy, maybe she can undergo before any repair. She can finish off the vaginal deliveries and then definitely.
No, you didn't got my question. I mean, when vaginal delivery is a good option for a woman who had a previous tear, in order to give her a trial of vaginal delivery. What are the indications for that?
Oh, when she is not symptomatic or anal manometry.
Yes, normal. Yes, normal investigations, normal endoanal ultrasound and manometry. So you need to tell her, because this patient didn't have a follow-up visit in her previous pregnancy, you don't have any idea about if the endoanal ultrasound is normal or there is a deficit within the muscles. So tell her we need to do a referral in order to do an ultrasound from the back passage to assess the tear. and depends on the result, we will discuss about the option. And detail here, if as long as you don't have any symptoms, and if you have a normal ultrasound, you can discuss now about the option of vaginal delivery, but at least to highlight these points. Am I clear, Dr. Lata?
Yes, ma'am. Yes, ma'am. Thank you
Apart
so
from
much.
that, you did it
Yes.
very well. Thank you.
Thank you, ma'am. Thank you very much for the opportunity.
So just to remember how we are going to approach the station of role player, just I'd like you to remember, in the 2 minutes, we need to highlight what points in the station. You need to be aware what domains being tested. Here, patient safety, information gathering, communication with patient, and applied knowledge. You need to know who you are. You are ST5, but remember, you are not going to tell the role player, I am ST5. I will tell her, I am Dr. Rasha, the registrar in the clinic. ST5 is a jargon for the patient. So who am I and where am I? I am here in the antenatal clinic. I need to know the topic I'm going to discuss. It's third-degree perineal tear, and the patient wanted to discuss about her mode of delivery. So in the 2 minutes, pick these points and pick if there is any part related to situation awareness. As you can see here, the consultant has been called away. So those are the important points you need to highlight. The domains, who you are, and where you are, and what is the topic, any issue related to situation awareness. And it is written in the 10 minutes, it's expected to obtain focused history and justify a management plan and answer the question of the patient. So be careful when you read what is expected in the 10 minutes. So this is what you are going to do in the 2 minutes. Read the station carefully, write down your notes, important point in safety and knowledge. When you remember, write it in your note, because inside the question you may miss this. So particularly what is related to this station, what are important points here? As we said, situation awareness, it's a guaranteed mark. When you say, may I see you on behalf of my consultant, because the consultant has been called away. It's important to confirm the aim of the consultation from the start. I understand that you are here today because you are pregnant in 36th week and wanted to discuss about your mode of delivery following a previous history of perineal tear. Is that correct? So I confirm it's the aim of consultation. Don't forget when the patient tells you that she experienced a bad experience of an ugly tear and what happened for her, show empathy. When she talk, your reaction and your face, you are affected or you are empathetic with her. I'm sorry to hear about that. It must be stressful for you. So be empathetic when she told you the story of the tear. And as Dr. Lata did, she started the consultation by an open question. Tell me more about your concern. What is your expectation? It's a really nice question to start the consultation. Open question. Tell me about your concern. Then it's written in the 10 minutes, you need to obtain focused history. Remember the point of focused history, what does it mean? It means that I need to ask questions in which the information given by answering this question will affect my management plan. Every information I'd like to know that could affect my management plan, this is focused history. Like what? Like I'd like to know about the details of her previous delivery. I would like to know if there is risk in her previous pregnancy which led to this tear, if this patient go into labor by herself or induced as in this role player. She has induction. Is there any instrument used, any forceps, any cut from down below, any history of prolonged labor? You need to know about the weight of her baby. All of these are the risk factors. So you need to know if there is any risk factor in her previous. Okay, especially if this patient is delivered by forceps, for example, you will tell her that because you have a forced delivery in your previous delivery, this increases the risk for this tear for this tear to occur. That's why your risk at that time is high. But in your current pregnancy, you will unlikely to require again forceps, so the risk will be less. So you will determine the risk factor and tell her some risk factor cannot be occur in this current pregnancy. Another point which can affect your management plan, her post-operative recovery. Any follow-up visit done for her? Did she practice pelvic floor exercise or not? Then you need to ask about current symptoms of perineal tear. And what are the symptoms? As you know, flatus incontinence and fecal urgency. What is the question to be asked to ask a patient about flatus incontinence? First, signpost. Sorry if you found some of my question intruding, but I need to ask, do you find it more easily to pass wind? This is the question. Do you find it more easily to pass wind? And when you ask about urgency, what you are going to say? Do you need to rush to toilet to open your bowels? This is the two important questions related to the perineal tear. Do you find it more easily to pass wind? And do you need to rush to toilet to open your bowels? And then ask about any problems with waterwork, any pain, and is these symptoms affecting her quality of life? It's an important question also, does it affecting your quality of life? Then ask about the current pregnancy. Another important point, the future fertility. Because this patient is keen to have 4 children, so you will be more toward vaginal delivery to avoid the risk of the cesarean. When you ask the role player, Dr. Lata, about the support at home, and I told you that my husband travel a lot because of his work, you can highlight this on counseling me. When you tell me that you will have a vaginal delivery, it's a good option because you will have a faster recovery and you will not require more support than as in the cesarean section. So it will suit more with your condition. So you can use the information from the patient to guide her in the counseling. Another issue in this station is that we need to do referral to do an endoanal ultrasound to assess the tear in muscle because this can change the recommendation for her mode of delivery. And remember that elective cesarean section offered only when the patient is still symptomatic or the patient has abnormal endoanal ultrasonographic defect. If it is the case, it's better to counsel her about cesarean. Anyway, you will counsel her about both options. You will tell the patient, we will have an open discussion about both mode of delivery. I will discuss with you benefit and risk of every option, and by the end, the decision will be yours. So you will help her to obtain her informed decision. So when you counsel her about the vaginal delivery, you will tell her about the risk. Be honest with the patient. There is a risk about 5 to 7% that the tear will occur again. And there is a risk 1 in 5 that your symptoms will appear again after the delivery. That's why what you are going to do. That's why you will be advised to practice pelvic floor exercise and to have a follow-up visit 6 to 12 weeks postpartum by consultant or rectal surgeon who may advise to have ultrasound from the blood passage to detect any defects in the muscle so they can put it back together. So when I will counsel her about the vaginal delivery, I will tell her the risk. Risk of recurrence of tear, 5 to 7%. Risk of recurrence of symptom, 20%. So what are you going to do? You will have a follow-up visit. You will advise to practice pelvic floor exercise. And we are going to deliver you in the hospital with a senior input. And you are going to support the perineal when the baby's head comes down, which means that perineal support on crowning. This will decrease the risk of recurrence of the tear. And don't forget by the end to give her patient information leaflet and access to support group. But as we said, this will be at the start of the consultation. Is it clear now? Anyone have any question related to this station?
Yeah, Dr. Asha, I want to ask one question.
Yes.
So if the antenatal patient at 36 weeks is saying that she is asymptomatic, means no bowel complaints are there, then also we need to tell her that about these studies, pressure studies of the back passage.
Yeah, you need to do an endoanal ultrasound because if she has a deficit, you need to counsel her more about the cesarean section. So you need to do that, yes.
Okay, so in the antenatal period also these studies can be done.
The endoanal ultrasound can be done during pregnancy, yeah. But the problem is its availability because it is not found in all trusts.
Mm-hmm. Okay, thank you so much. Yes, yes.
Any more
Dr.
questions?
Rasha,
Yes.
how are you, Dr. Rasha?
Yeah, fine, thanks, Dr. Ansar. How are you?
Fine, thank you, doctor. Shall I ask about the sexual history?
Yeah, pain on having sex. Yeah, this is in the specific symptom. When I ask about the pain, I mean pain on having sex.
Pain, or I'm sorry to say, there is no satisfaction upon sexual intercourse because she feels wide, or she feels that the muscle, her muscle is weak. Maybe
you may ask this question. Yeah, all of those are specific symptoms related to the perineal tear.
Yes, ma'am. Yes, ma'am. Thank you, ma'am.
You're welcome. Any questions?
Hello, Dr. Rasha.
Yes. Hello.
You mentioned about postnatal scan. This is a routine to do for her, or just if she's symptomatic?
If
For
she's
example,
symptomatic, you can do referral for her at that time. And some trust, it's not clear this point in the guideline, but some trust do even if the patient is asymptomatic to document this, if the patient has tear or
after
not.
each delivery, you mean, even if not have
If
tear?
she, no, if, from the start, if she suffered perineal tear, on the follow-up
Yeah.
visit, she will have follow-up visit, and on the follow-up visit, she may offer to have endoanal ultrasound even if she become asymptomatic.
As she
But
has
not-
history of tear.
Oh, yeah, but not if it is a current pregnancy with only previous history in her previous pregnancy. No, at the time you will do only the endoanal ultrasound if the patient presents symptomatic. But if she is asymptomatic in the postpartum follow-up, no need for the endoanal ultrasound.
Okay, you mean after initial tear, but if she
Yes.
has history, unless she's symptomatic.
Yes, yes.
Okay, thank you.
You're welcome. Any more questions? Shall we move?
Excuse me, Dr. Asha.
Yes, Dr. Sama.
Yes. Can you explain that to reduce this perineal care, that we can give her that warm bath and massage in the second stage of the labor in between contraction?
You can add this, yes, you can
Yeah.
add. But the main point is the supporting the head during crowning. This is the main point that you don't need to miss it. But if you need to add this, yes, you can add it.
Okay, thank you.
You're welcome. Shall we move? Okay. Who would like to chair the last station?
Can I try, ma'am?
Yes, Dr. Nisa.
Yes, ma'am.
Okay, this structural discussion task is aimed to assess the following domains: information gathering, applied knowledge, communication with colleagues, and patient safety. You are an ST5 and have been called by midwife to review a woman who was just delivered. The delivery was complicated by third or maybe fourth degree perineal tear. The examiner is playing the role of your consultant and will ask you the following question before you start the management. What's your immediate action? How can you identify the type of the tear? What are the types of sutures materials and the technique used for the repair? What is the post-operative management and what is the recommended mode of delivery for her next pregnancy? Take your time for preparation. You have 2 minutes from now. Are you ready, Dr. Ansar?
Yes, ma'am.
You please start.
But forgive me if I'm not prepared. Okay.
Okay, no problem.
Okay, ma'am. Hello, I am Dr. Ansar Abdel Qadir, one of the exam candidates. I read the scenario. I am ready for the exam. I'm ready for the
Okay.
discussion.
So what is your immediate action and how can you identify the type of tear?
My immediate action is that I will go to the patient and I go to review the patient and to take a short history from her, introduce myself to her and know her name, and you want to ask her about her pregnancy, shortly about her pregnancy, about her labor. Is this the prolonged labor? Is that is what difficult labor? Is she any instrumental? She undergone any instrumental delivery? The weight of the baby, and then I will tell her that the midwife. Of course, this is in the presence of the midwife that deliver her to ensure about these informations. Then I will tell her that, ma'am, I want to tell you that there is some sort of tear has happened in the muscle which is around your back passage, and we are in need to transfer you to the theater in order to identify the type and to ensure the type of the tear, whether and its degree. And this should be under general anesthesia. So I will take consent from her to go into that theater and a written consent and approval to go to the theater to examine her, and if there is her consent and her approval to suture the tear present. So
and how are you going
will
to examine her to know the type of the tear?
This will occur, ma'am, in the theater under general anesthesia. So I will ask to prepare the theater and to call the anesthetist to call the staff nurse in order to prepare the theater for examination and for repair of the tear.
Okay. Did you finish?
Yeah, during under general anesthesia, ma'am, and under good light, and after preparing all the ensuring that the staff member preparing the trolley suitable for identifying the tear and suturing the tear, I will try to see the degree of the tear, whether it includes whether it is a third degree tear or fourth. The third degree tear, it have different grades. That is to say, either it involves less than 50% of the external anal sphincter, or more than half of the external anal sphincter, or it includes also the external and internal anal sphincter. This is the third degree. But if beside that it will include also the mucosa of the anal mucosa, it is a fourth degree tear. So according also, I will introduce my finger into the rectum to ensure that the rectal mucosa is intact and there is no hole tear in the rectum, and exclude it also that the injury of the anal mucosa reach the rectal mucosa.
Okay. What are the types of suture materials and technique used for the repair?
Usually, we use two types of suture: either polygalactin suture 20 or 30, or polydioxanone suture 30. For the suturing of the external anal mucosa, we usually use the polygalactin suture 20. And 20 for the external anal sphincter.
Okay, from
For the
sphincter,
internal
okay.
anal sphincter, you can use polygalactin 20 or polydaxinone 30. And for the anal mucosa, we use polydaxinone or polygalactin 30 sutures.
Okay.
Usually, we resort to the interrupted sutures, and the external anal sphincter, usually we do it, if complete tear of it, we usually do end to end. But if partial, we can resort to overlap. But the internal anal sphincter, we resort to interrupted suture end to end. And the anal mucosa usually interrupted, and also trying to approximating the mucosa edge together with polygalactin 30.
Okay, perfect. Okay, what is the post-operative management?
Of course, after post-operative, I will debrief the patient, and I will debrief the patient and act the duty of condor to explain to the patient after she is coming out of anesthesia everything that happened honestly. What happened actually? What is the degree of the tear, and using the suture material we use it for it, and we will plan. We will plan with her the follow-up management with her. Also, I will give antibiotic to the patient. During surgery, I will give her antibiotic and enough analgesia because it is a painful condition. Also, I will advise the patient to take fluididide in the first few days after delivery, to avoid tension on the suture, to allow this to be loose stool, to avoid tension on the suture.
Okay. And what is your immediate post-operative management? Immediately following the repair, what are you going to do?
I will enter also my finger. I will examine the suture. I will enter my finger also into after the surgery to exclude any rectal injury or a hole in the rectum, and that everything is approximated and become intact, no defect in the sutures. Also, I will complete the tear after completing after repairing the sphincters. I will resort to this I think I forget to say that in the previous one, that to complete the suture of the episiotomy, the first and second degree tear, which is already present with the. Also, I will immediately I will ensure that there is no swabs left to count the swabs, and nothing is missed from the trolley by the nurse. Also, we'll debrief the whole team about that. And also, I will have to write an incident report about the occurrence of the third or fourth degree perineal tear.
What is the recommended mode of delivery?
Yeah, about that, this will depend upon the post-operative management plan for the patient at home. So she has to come to the consultant or to me after 6 to 12 weeks from the delivery to ensure that everything is all right, and to know if the patient is still symptomatic or not, if she develops symptoms, pain, any abnormal symptoms, especially about bowel habits, if she is under good control of her weans and her stool. Also, I will advise the patient to perform pelvic floor muscle exercises. So I will refer her to the physiotherapist to ensure that the muscle will retain her strength again. And if the patient show continuous symptoms and the symptom doesn't disappear after a while, after several weeks, I will advise her to do an endoanal ultrasound to see if there is still a defect in the muscle that could be repaired by an anal surgeon after that. So that if after 1 year from the repair of the tear, the patient come to me and she is completely well, she is the bowel habit under good control, and she didn't complain of anything or nothing affect her quality of life, such as pain, such as uncontrolling of the, such as rushing in urgency to go to the toilet, to open her bowel, any sexual problems. So I will advise the patient to another trial for a vaginal delivery if she becomes pregnant again, after ensuring that the muscle is working well.
Time's up.
Yeah,
Okay.
and of course, I will provide the patient upon discharge with patient information about her condition and about the advices to be given to her following the repair of the anal sphincters. Also supporting groups for those patients who undergone the same condition, and my contact number if she develop anything during the first few weeks after delivery to contact me or to come at the hospital at once.
Okay. Any other thing you'd like to add, Dr. Nisar? May I ask you a
No,
question? How are you going to distinguish between the external inner sphincter and the internal inner sphincter on examination? How can you identify?
About usually about the size and the color of the muscle.
Yes.
Because the external is more superficial than the internal. The internal is deeper and more lighter in color.
Okay. Okay. Thank you. Okay, Dr.
Thank
Nisar,
you.
you did very nice, and you covered most of the points, but you forget some issues. So, in terms of what you covered, when you say about you need to gather information, when you come to the mother, you need to introduce yourself. You need to ask about the risk factors, like if she has an instrument delivery, what about the baby weight. It's very nice also that you mentioned about you need to take her permission to move her to the theater. And you didn't forget about the consent, and you mentioned the classification correctly, and that you didn't forget to count the swab and instrument. You said about debriefing the team and the woman and writing the incident report, and most of items in the post-operative management, you covered it very well, and you said about the mode of delivery correctly. But I'd like you next time to add this point. As long as it's an obstetric emergencies, third and fourth degree perineal tear are obstetric emergencies. To give me the sense that it's an emergency, I will rush to the theater or to the midwife, assess the patient, and first you need to assess ABC approach. Make sure that the patient is not in bleeding, which could affect her hemodynamical status. So as long as it's an emergency, you will go quickly to respond to the call of the midwife, and when you enter, you need first make ABC approach. In all obstetric emergency, don't forget this. Another issue that when you mentioned about rectal examination, this need a separate consent from the woman, because it is nothing usual to do for her a rectal examination. So you need to justify why you are going to do the rectal examination and what are you going to do. If she accepts, you can do the examination now, but don't mention rectal examination without telling the examiner that you need a separate consent for that. Another issue is, anyway, when you are talking in post-operative management, remember to categorize your answer in two categories: immediate post-operative and delayed post-operative. Immediate, you are still in the theater, so you need to count the swab and an instrument and repeat rectal examination after the repair. You need to ensure that there is good hemostasis. All of this immediately, and immediately also the patient will have post-operative. Later, sorry, you will prescribe for her antibiotic, advise her to practice pelvic floor exercise. Then late, you will discuss about the follow-up visit and when she could be referred for the colorectal surgeon, and discussing about the mode of delivery. And also don't forget documentation. Very important to document the type of tear and the sutures used in the repair and what method used for the repair. This needs to be clearly written in the documentation. Another issue, generally, when you mention that you move to the theater, do not forget WHO checklist. It's a very important point of safety. Once you said theater, immediately WHO checklists. Okay?
Yes, ma'am.
Apart from that, you did it very well, Dr. Nisar. Thank you for your performance.
Thank you, ma'am, for allowing this opportunity to me. Thank you, ma'am.
You were welcome. So, just to revise again, what is your immediate action and how can you identify the type of the tear? As we said, as long as it's an obstetric emergency, so I will respond quickly and go to assess the situation. And when I enter, I will introduce myself, take permission to assess the mother. I will start by ABC approach because it's emergency. After making sure the patient is hemodynamically stable, now I will collect my information. I'd like to know about the risk factor. If this labor is induced or spontaneous, any forceps used, what about the baby weight, what type of pain relieving method used, if she's in epidural or what. Then I will examine the woman in presence of a chaperone. Once I said examination, don't forget the chaperone. And in this examination, as I said, the rectal examination is very important. And when you mention rectal examination, you will explain to the mother why you will need to do this examination and obtain her consent for that. How to do this rectal examination? You will introduce your index finger in the woman's anus, then ask the woman to squeeze. When she squeezes, you can feel that there is loss of contraction around your finger if there is affection of the sphincter. But take care that if the patient is under epidural, her ability to squeeze may be affected. So if the patient under epidural and you did the rectal examination and ask her to squeeze, sometimes you cannot feel the contraction. But this is not enough because the patient is affected by the epidural. So what other point I can do in the rectal examination? If there is torn sphincters, you can see the sphincters retracted towards the ischiocrectal fossa on squeezing. You can see loss of conjugation all around the anus or any part around the anus. You can do bell rolling movement, introduce the index, and using the index and the thumb to roll all around the sphincter. By this examination, you can feel any defect in the sphincter. So, as you can see here in this image, the external anal sphincter, it appears, look here in this arrow. In this part, this is the part of external sphincter. It appears like beef. Remember this. The external is like beef, while the internal is like chicken. External anal sphincter is red in color. It's a striated muscle, red in color, like beef. And as you know from its location, it is superficial to the internal sphincter. But the internal sphincter is white in color, as you can see here in the arrow. This is the internal sphincter. Here, the internal sphincter is white in color, and it is like color of a chicken. So the internal sphincter is pale, and the external sphincter is red in color when you compare both to each other. So as you can see here, this is the internal sphincter, it's intact. So this is 3rd degree tear, not 4th degree. Classification of the trauma, as you all know, we have 4 degrees. The 1st degree, in this image, there is only cut in the perineal skin and the vaginal epithelium. 2nd degree, including the muscle. 3rd degree takes the sphincter and could be subdivided into 3A and B and C. A less than 50% of the external sphincter, 3B more than 50% of external sphincter, and 3C, both external and internal sphincter are torn. And the 4th degree, which extended to the rectal mucosa and the anal epithelium. And you can mention also about the rectal buttonhole tear, which meaning that there is tear in the rectal mucosa while the sphincter is intact. And you need to recognize it, because if it doesn't repair, it could lead to rectovaginal fistula later on. So again, how can I examine woman in labor complicated by perineal tear? I will first inspect. What I can see on inspection, I can assess the amount of bleeding from the start, and I can see that absence of absence of corrugation around the anus. This is by inspection. Then I will do rectal examination with permission of the mother. I can feel absence of contraction of sphincter, but be careful if the patient is under regional anesthesia, she is taking epidural, denervation can occur leading to deficient contraction. But still, on squeezing, I can see the separated end of the torn sphincter retracted toward the ischiocrectal fossa. Another sensitive test to be done, named bell rolling motion test. How can I do this test? You will introduce your index in the anus. With your thumb, roll it all around the sphincter to detect any defect in the muscle, in the sphincter. And this is a sensitive test, and if done properly, it will be as sensitive as the endoanal ultrasound. So it's a very important test, bell rolling motion test. Then coming to the point of the repair. The repair need to be performed by experienced person. and who are trained on this repair. And this need to be done in the theater, so WHO checklists need to be done under aseptic precautions, adequate lights, and proper instruments and proper analgesia. The patient to be under either regional anesthesia, epidural, or general anesthesia. Coming to the sutures, methods, and material and methods. The 4th degree tear, we do the repair using polyglactin 3O. This is the suture material. Remember, polyglactin can be used for both 4th degree and 3rd degree. The 4th degree, the anal mucosa, we need finer sutures material, so it will be 3O. While the internal sphincter and external sphincter, we can use 2O polyglactin or 3O BGS. This is to the suture material. But what about the method? The 4th degree tear, the anal epithelium, we can use either continuous or interrupted. The internal sphincter, we can do either interrupted or matrix. The external sphincter, it can be overlapping technique or end-to-end, depends. If it's 3A, only end-to-end. But if it's 3B, you can use overlapping technique. Remember to mention that in the internal sphincter, we cannot use overlapping technique, and we cannot use in general figure of 8 because it could lead to ischemia. Another important point, remember, it's a 3rd or 4th degree tear, still you need to suture the muscle and the skin. Don't forget this part. In terms of muscle and the skin, we can use polyglactin, Vicrorapid. In the muscle, you can use the method of loosening continuous non-locking technique. This is for the vaginal mucosa and the perineal muscle. While the perineal skin, we can use continuous subcuticular technique. So, in the suture material and method, take it systematically. Anal epithelium, what suture and what method? Internal sphincter, external, muscle, and the skin. And finally, don't forget to tell that the surgical nose need to be under the superficial perineal muscle to avoid node migration. Then, after completing the repair, repeat again the rectal examination, again with permission of the mother, to make sure that no sutures material are included within the anal epithelium. If it is the case, you will remove and re-sutures again. Don't forget at any post-operative immediately proper hemostasis, count swab, and proper documentation and debriefing. Documentation here, you need to document what? The degree of the tear, the type of suture material, and the technique. Debriefing is for both the mother and the team. Coming to the post-operative management, the patient will be prescribed broad-spectrum antibiotic, laxative, and you need to avoid bulking agent. There is another common station about discharge letter written by a junior doctor who write for the woman whose types of laxative and there is bulking agent. In this station, you need to mention that don't give the patient the bulking agent, only give her softening medication to the stop. Don't forget about the physiotherapy and the pelvic floor exercise and the follow-up visit within 6 to 12 weeks postpartum. Don't forget to write back to the GP and to mention that if the patient is still symptomatic, at the follow-up visit, you will counsel her to do a referral for a colorectal surgeon or a specialized gynecologist to do the endoanal ultrasonography and anorectal manometry to see if there is any defect of the muscle. At this time, she can do second repair. And as you know, counseling on the subsequent mode of delivery depends. If the patient is still symptomatic or have abnormal endoanal ultrasound or anorectal manometry, we can offer elective cesarean section. But if she is become asymptomatic with normal endoanal ultrasound and anorectal manometry, we can offer vaginal delivery. And finally, don't forget the risk management issue, including incident report, training the staff, and auditing our service, all as you know about the risk management. Okay? Anyone have any question related to this station? Is it clear now?
Thank you, ma'am. May I ask you a question, ma'am?
Yes.
If the patient remains symptomatic and go to a colorectal surgeon and undergo a second surgery, and then everything become okay, and she is not symptomatic anymore, and everything, and the endoanal is good. Shall we, after a second surgery, also give her the opportunity to deliver normally?
This point is not mentioned in the guideline, but you need to outweigh the risk and the benefit. If she now asymptomatic and she has normal endoanal ultrasound, still you can offer vaginal delivery. Depends also on the situation. If she has future fertility wishes, or this is the last delivery, so it will be individualized according to the case. But it is not mentioned in the guideline what to offer following secondary repair. I think it is beyond
Okay,
the level of MRCOG exam.
yes, ma'am. Thank you very much, ma'am. Thank you.
You're welcome.
And we are happy to hear you again, ma'am. Really, we are happy.
And me also. I
Thank
miss
you,
all
ma'am.
of you. Thank you. Thank
May
you.
may your father be in good health all the time, ma'am.
Thank you. Any more questions there?